Welcome to this Expert Explainer briefing. Today, we're examining a live operational infrastructure designed to resolve Africa's escalating non-communicable disease epidemic. Now, for the policymakers and public health officials joining us, the blueprint we're unpacking today moves way beyond theory. We're looking at a system that is actively functioning right now to save lives and, frankly, entire economies. Let's get into it. So let's start at the macro scale. Right now, 130 million adults in sub-Saharan Africa are living with undiagnosed hypertension. And to put that massive number into perspective, fewer than 40% are even aware they have it. This is what we call the silent thief, and it's operating completely undetected all across the continent. Now, what does that actually mean for our health economies? Well, it translates to a staggering projected cumulative economic burden of literally $1 trillion by 2030. That is a massive, continent-wide drain on national resources, and it's driven almost entirely by a lack of preventative, connected health infrastructure. But the human cost is just as alarming. Non-communicable diseases currently account for 37% of all African deaths. And without immediate systemic intervention, this figure is projected to hit an astounding 46% by 2030. We're looking at the most preventable deaths on the fastest-growing continent being driven not by a lack of medicine, but by a lack of infrastructure. Okay, here's our agenda for this explainer. We'll cover the silent healthcare crisis, the faces of unified care, erasing geographic barriers, the 5 infrastructure layers, economic scale, and finally, policy mandates. Section 1. The silent healthcare crisis. Look, right now, our legacy systems are failing across 4 specific dimensions. We have the silent thief, undiagnosed conditions advancing in the dark, the empty fridge, when a local pharmacy just runs out of life-saving medication, the appointment void, those really dangerous unmonitored gaps between clinic visits, and the fragmented picture, disconnected medical records where doctors are essentially flying blind. And the crazy thing is, these 4 gaps exist simultaneously in every single city and clinic. Section 2. Faces of unified care. To truly understand how to fix this, we need to look at the human level. Take Emmanuel in Kumasi, Ghana. Under the legacy system, Emmanuel felt completely fine, totally unaware of his hypertension. But with the care grid, a proactive AI sent a simple Twi language check-in straight to his phone. His elevated blood pressure was flagged remotely, and a virtual consultation was scheduled within 24 hours. A major crisis was safely intercepted before it even began. Then, think about the supply chain reality for Abena, also in Kumasi. Historically, when her pharmacy ran out of insulin, she was forced to dangerously adjust her dose or just go without. The care grid completely changes that. A predictive refill alert was sent 7 days prior to her running out, and she was automatically redirected to a verified pharmacy with full stock just 1.8 kilometers away. She never has to guess or adjust her dose because the system actually anticipates her needs. And then there's Chidinma over in Ngu, Nigeria. She has 4 separate doctors, and previously, no one had the complete picture, which risks dangerous drug interactions. Through the care grid, her health vault flagged a severe interaction before a new drug was even prescribed. A multi-specialist virtual consult was held, allowing all 4 of her doctors to collaborate using a single source of truth. It's an incredible transition from fragmented care to a unified, patient-controlled experience. Section 3. Erasing geographic health barriers. So what's the engine making all of this possible? It's AfriPharm Health. The source material outlines that this is complete, connected, and continental. And it is absolutely crucial to note that this is not some pilot program waiting for funding. It's a live, operational infrastructure stack running across multiple markets today. As the source highlights, this connected care infrastructure stack closes every gap simultaneously, continuously, and at scale. It literally follows the patient. It bridges those gaps whether a patient is in a rural village or a major capital city, completely bypassing traditional geographic limitations. Section 4. The 5 infrastructure layers. Okay, so here is the actual blueprint of the care grid. 5 interconnected layers working together. Dr. Cheerful for proactive AI, the Health Vault for the whole patient record, the virtual care network for telehealth, the pharmacy partner network for supply continuity, and the connected ecosystem linking hospitals, emergency services, and home care. It operates offline first, from proactive community screening right down to verified home delivery. Let's look a little closer at Layer 1. Dr. Cheerful is a multilingual proactive care AI. It engages patients in those crucial 90 days between appointments in their native languages. We're talking Twi, Nyanja, Hausa, Swahili, and Zulu. It prevents clinical regressions by being the continuous clinical presence exactly when the patient isn't in the doctor's office. And then we have the Health Vault. This is a patient-controlled digital record that is FHIR-compliant and blockchain-anchored, which basically means it's globally standardized and highly secure. It unifies every prescription, clinical note, and dispensing event. This is the ultimate infrastructure of continuity, a fully portable health passport controlled entirely by the patient, making cross-border care incredibly safe and efficient. Section 5, Economic Scale and Opportunity. So when we cross-reference those massive macro burdens against the care grid resolutions, the systemic return on investment becomes undeniable. I mean, remote monitoring leads to a 34% reduction in cardiovascular events. Shared electronic records yield a 50% reduction in medication errors. We're talking about converting a $1 trillion burden into a structured, manageable system of proactive care. And here's a crucial point, because it's genuinely built for Africa's digital reality. It operates flawlessly across the continent's 615 million mobile internet users. It's explicitly optimized for 2G and 3G networks, and boasts robust offline-first capabilities. You do not need high-speed broadband to save a life with this infrastructure. Section 6, Mandates for National Health. The infrastructure's built. It's working right now. So the real question is, who needs to be in the room to scale it up? We have the blueprint, but who needs to take immediate action to make universal health coverage an everyday reality for millions? Here's the playbook for scaling. Hospitals and pharmacies must plug into the network for pre-verified patients and national health insurance revenue. Governments absolutely must align their mandates by requiring FHIR compliance and funding Dr. Cheerful deployments at the primary care level. Regulators need to adopt digital prescription tokens to structurally eliminate fraud. And investors? They have a massive market opportunity to capitalize on a scalable, Web3-powered NHI framework that introduces next-generation security and efficiency. I want to leave you with this final, provocative thought. The infrastructure to end Africa's $1 trillion silent healthcare struggle is live today. We are no longer waiting for the technology to catch up. So, to the health ministers and policymakers watching, are you ready to plug your national health system into the care grid, or will you let the silent thief keep working? Thank you for joining this explainer briefing.